Thank you, Loren. And Loren has actually been at our clinic quite a bit because we're trying to foster some interest in Saskatchewan, which is critically underserviced and very rural and often indigenized. And we actually have 4 nurses at Origins Dermatology, and Loren has been able to see how we use that multidisciplinary team to bridge those gaps. So thank you, Loren. Wonderful presentation. So I'd like to next introduce, we have a trio here, but we have only 2 presenting. We have our medical students, Jonah, and I'll start with him. So he's a medical student here at the U of T. He has a bachelor's degree in biochem from Winnipeg. He has previous research actually on autoimmune and inflammatory disease and traditional Indigenous medicine. He's worked with Knowledge Keeper elders in Manitoba, I think in Cree Nations, to synthesize and distribute natural medicine to northern communities. So as a medical student, he's continuing his research and also is developing a rural skin guide that I'm also the supervisor on. He's doing a wonderful job for primary care providers in rural communities. So we'll probably highlight that next year at our Skin Summit. I'd also like to introduce Polycronis from Toronto. So he's also a medical student, holds an honors Bachelor of Medical Science in Biochemistry, of Infection Immunity, and a Master of Science in Microbiology and Immunity from Western. He has previous research experience on biochem and micro, particularly the role of microbes in human health and therapeutic potential of probiotics. So you might have found Dr. Jackson talk interesting. He also has been awarded an NSERC scholarship for his work on novel metabolic functions of commensal organism and its potential probiotic applications. That could be relevant to atopic dermatitis. As a medical student, he's developed strong interests in vascular surgery and ongoing research project in investing wound care practices, so also skin as well, in Indigenous populations, and is working on creating a machine learning tool for intraoperative guidance during fenestrated endovascular aortic repair. So excellent work, Polycronis. And then we have Sierra. So Sierra graduated from Western recently with a bachelor's in medical science, specializing in interdisciplinary medical science, also a very needed field, with honors. Her primary interest in medicine lies in addressing the needs of marginalized communities. She's engaged in research examining barriers faced by members of Nishnawakasik, maybe I could get you to pronounce that better, Cree Nation in accessing healthcare. Sierra is particularly focused on exploring the role of Indigenous traditional medicines, drawing insight from elders and medicine people to promote the integration of traditional practices into mainstream healthcare. She's also collaborating with the palliative care team at Princess Margaret Cancer Centre in Toronto, looking at supportive care and end-of-life care. So I'd like to welcome our trio here, and they are going to be speaking about a novel primary project that was conducted in Manitoba at Nelson House. Okay. So welcome.
Thank you, Dr. Sinwasis, for the kind introduction, and thank all of you for attending today. Today I'd like to present on some very important findings of a qualitative study that we conducted at a reserve in northern Manitoba, one of which I've been connected with for many, many years, and the findings are truly novel, so I'm very excited and eager to present those today. We have no conflicts of interest. So the background here that inspired our study is the fact that a recent study analyzing First Nations peoples living on reserves showed that many felt that the reason they weren't seeing regularly a physician was because there was a lack of access to care. But if we look at the NIHB program benefit expenditure, medical transportation is astronomical. That's the one in blue. So there's an obvious disconnect here because so many resources are going into ensuring that folks living on reserves are able to access the necessary resources. But what we see is these same individuals are reporting that in fact there is no access to these resources. So what we've heard here today, time and time again, is what's important to do is to connect with the actual Indigenous First Nation themselves and ask them about that experience, which is what we did. Nelson House, Manitoba is a community of 5,000, home to the Nishnawakasik Cree Nation. And if anyone from NCN is listening today, I think there might have been a few, shout out. And it's located 850 kilometers north of Winnipeg, which is where I'm from. And they have no full-time access to a physician there. It's virtual care. And there's huge inequities in access to health care as a result. And we came up with the idea for this project with some of the elders and medicine people of the community who I connected with before, and we designed a project with the goal to understand and address the experiences of patients living with chronic skin conditions to promote both holistic care and improve the health outcomes in their community and hopefully in the future other northern Indigenous communities. We held a general dermatology clinic there with a dermatologist from Manitoba, and through this clinic we appraised patient interest. So we said, are you interested in participating in this study? Explained it, and we got consent. And the patients were then grouped into 4 cohorts, one being diabetes and chronic vascular conditions, acne, rosacea, psoriasis, and atopic dermatitis. And of course, all of the methods were designed and reviewed with both the Indigenous elders and medicine people who we collaborated with, as well as Dr. Sinawasis, who provided a lot of guidance. And we did a thematic analysis on the different transcripts that we received, and we discovered some very interesting thematic domains as a result. So if we look at the overall results, compounding all of the different conditions, we see that overwhelmingly the 2 most prevalently mentioned themes were lack of access to health care. Unsurprisingly, there's no access to a primary care physician in the community of 5,000, unshockingly. And as a result, significant quality of life detriments amongst patients. These are patients presenting with advanced stages of disease, and it was very eye-opening and quite sad in some cases to see. A lot of patients, and this is something that we haven't heard a whole lot of in some of the presentations today, but a lot of patients discuss their traditional medicine use. And traditional medicine use in managing skin conditions is quite prevalent in northern communities. And as my colleague here will elaborate on, many didn't feel comfortable discussing that with their primary care physicians or dermatologists, which is definitely an eye-opener for the need for cultural competence in healthcare. Many reported a lack of education from their healthcare providers on how to manage their skin conditions, what are causing their skin conditions. Many hadn't even heard the names of the diagnosis that they received of what their skin conditions were. And quite a few reported systemic or local at the level of patient-healthcare provider interaction, discrimination on the basis of their Indigenous identities. I'll pass it over to my colleague here to report specific results to each condition.
Okay, so looking at the results from interviews conducted with patients living in Nelson House, we interviewed them to investigate the barriers they experienced in accessing healthcare in their community. And the first cohort of individuals that we interviewed with were those diagnosed with psoriasis. Among this group of patients, there were 72% who mentioned advanced stages of their disease. One patient shared, like I said, it gets really thick with calluses, explaining the symptoms that they experienced of their psoriasis. And when questioned about how they managed these symptoms, they revealed that this was largely self-medicated. Reflecting on what this patient shared, among others we interviewed with, it highlighted the severe symptoms that patients were experiencing in regards to their psoriasis and the lack of access to early treatment, which underscores the need for improved access to early treatment and care for patients specifically living with psoriasis in this community. Our next cohort of patients were those diagnosed with atopic dermatitis. And in this group, there was a 91% frequency of patients who admitted to having learned to accommodate their symptoms independently. One patient shared with us that my skin condition, it is debilitating in the morning. I have to walk slowly, and then I have to use constant, deep penetrating moisturizers just to make sure my skin doesn't crack. Patients also shared their experiences with cultural barriers when accessing healthcare, as well as psychological impacts because of their atopic dermatitis. And the intersectionality of their disease is highlighted here by not only the physical symptoms they experienced, but things like psychological as well. Okay, in our next cohort of patients, we interviewed with those diagnosed with acne and rosacea. And there was a frequency of 86% of patients who revealed that there was an impact of their diagnosis of acne and rosacea on their mental health. One patient shared that you couldn't go to work, you couldn't go anywhere, right? And I couldn't come to work, emphasizing the impact of their symptoms on their confidence and appearance for up to 2 weeks. clearly impacting their daily life. And in our final group, our final cohort of patients, we interviewed those diagnosed with diabetes and other chronic vascular conditions. Patients shared that, I haven't seen a doctor about that, I just do it on my own. And clearly this emphasizes the lack of attention and resources and healthcare providers that are allocated to these patients to attend to their specific needs and specific challenges with their diagnoses. Patients also revealed that they had a willingness to discuss traditional medicines with their healthcare providers, but they did not feel comfortable in doing this. So reflecting on the experiences that were shared by patients generously with our community and with our team in their community, they revealed that there is a need for improved cultural competence among their healthcare providers working specifically within their community to target towards their specific needs.
So clearly, there's some deep-rooted issues with access to care. And calling on my own reflexivity and realizing that those living in the community have arguably the most valuable opinions and insights as to what the solutions for some of these issues are, we called to members of the community during these interviews and we said, what do you think can be done about this solution? If you were put in charge today and you were given the option to implement meaningful change, what would you do? And this is what we came up with. And unsurprisingly, much like many of the multi-layered graphs we've seen today for future directions, it's multi-laminar. But at the top of all this is, of course, the Truth and Reconciliation Commission's call to action and better integration of traditional Indigenous health practices to Western-centric health practices. And you can read some more of those solutions there. So I would like to thank the Nishawashik Cree Nation Family and Community Wellness Center for having us, for helping so much with this study, participating in the study. I'd specifically like to thank a mentor of mine, an elder, knowledge keeper, Felix Walker, who I've worked closely with for many years at Nishawashik Cree Nation. And thank you all so much for listening today.